Hi everyone, this is Jeanne E. Poole, the editor-in-chief of the Heart Rhythm O2 Journal. This is the September 2025 podcast. Because we have so many papers in this issue, I'm going to be reading the title of the paper, giving you the first author, and either the key points or the conclusion. It starts off with a review paper titled Innovation. This is a brief paper written by Hamid Ghanbari. Dr. Ghanbari is the deputy editor-in-chief for Heart Rhythm O2's Digital Technology and Innovation section. You will be seeing a lot of papers from Dr. Ghanbari, including some planned extensive review topics over the next year. So I hope you take some time to take a look at this. Next is a paper titled Integrating Wearables into the Modern Electrophysiology Practice, a proposed framework for the use of wearables and creation of a remote digital clinic by Dr. Krishna Pundi and colleagues. This is a white paper. The conclusions that are provided by the authors read as such. This white paper summarizes the perspectives and recommendation of members of the Heart Rhythm Society Digital Health Committee on integrating wearable monitors into clinical practice through a patient-centered, indication-specific, and evidence-guided approach. Owing to the dynamic nature of monitoring technologies, data processing, and clinical management, these recommendations should serve as an organizing framework that continuously responds to technological innovation and advances in clinical research. In the future, end-to-end encrypted data streams between patient wearables and remote monitoring clinics with automated interpretation and robust reimbursement schemes can serve to accelerate guideline-directed cardiac rhythm care, improve patient engagement, and reduce healthcare costs. The title of the next paper is Enhancing Explainability in Clinical Deep Learning Models. Latent Space Variable Decoding is Superior to Gradient-Weighted Class Activation Mapping by Dr. Richard Carrick and colleagues. Here are the key findings. 1. Both traditional residual network-based ECG deep learning models and intrinsically explainable variational autoencoder models can offer comparable performance in the diagnosis of high-risk hypertrophic cardiomyopathy features using 12-lead ECG. Second, saliency analysis with gradient-based class activation mapping has low reproducibility and high interpatient variance, thus offering little meaningful insight into ECG DL models' underlying decision-making processes. Next, VAE models offer an alternative approach to saliency analysis, latent space variable decoding, in which a representative ECG for a specific group, such as patients with left ventricular apical aneurysm, can be directly visualized, thus enabling reliable identification of ECG characteristics critical for diagnosis. Next and final, use of the Kolmogorov-Smirnov goodness of fit test for assessing differences between the ECG characteristics of patients with and without a particular diagnosis, such as massive LV hypertrophy, offers insight into the solvability of that diagnostic problem. Failure to reject the null hypothesis raises suspicion for model overfitting to a specific data space. The title of the next paper is In-Hospital Complications of Hybrid versus Endocardial Atrial Fibrillation Ablation by Dr. Mahmoud Isa and colleagues. And here are the key findings. First, hybrid ablation was associated with a significantly lower risk of in-hospital major adverse cardiovascular events compared with endocardial catheter ablation based on propensity score-weighted analysis of a large national data set. Second, rates of cardiac, infectious, and thromboembolic complications were comparable between the two groups. Third, hybrid ablation was associated with increased rates of hemorrhagic and pulmonary complications, though blood transfusion requirements were similar. Fourth, multivariable analysis confirmed the robustness of these findings, reinforcing the importance of patient selection and identifying coagulopathy and fluid or electrolyte disorders as independent predictors of MACE. And finally, these results highlight the evolving safety profile of hybrid ablation in contemporary practice and support its use in appropriately selected patients. The title of the next paper is Pulsed Field Ablation versus High-Power, Short-Duration, Very High-Power, Short-Duration Pulmonary Vein Isolation. Systematic Review and Meta-Analysis with Kaplan-Meier Reconstructed Individual Patient Data by Dr. Raymond Pranata and colleagues. The key findings are, first, pulse field ablation was potentially associated with a comparable or reduced rate of atrial tachyarrhythmia compared with high-power, very high-power, short-duration ablation, as demonstrated by pooled binary outcomes, reconstructed individual patient data regression, and survival analyses. Second, the benefit of PFA in reducing atrial tachycardia's recurrence was not significantly influenced by the presence of paroxysmal atrial fibrillation, sex, age, hypertension, or left ventricular ejection fraction. Third, there were no significant differences in the number of repeat ablation procedures or in the incidence of pulmonary vein reconnections during repeat interventions. Fourth, although the total procedure time was shorter in the PFA group, fluoroscopy time was longer compared with the high-power short-duration, very high-power short-duration ablation group. And finally, complication rates were similar between the PFA and the high-power short-duration, very high-power short-duration ablation groups. Next up is a paper titled H-type hypertension and U-shaped body mass index predict atrial fibrillation recurrence after catheter ablation, insights from a 3-year follow-up by Dr. Jeanne E and colleagues. And here are their key findings. 1. H-type hypertension was identified as an independent risk factor for long-term atrial fibrillation recurrence after radiofrequency catheter ablation. A U-shaped relationship was observed between body mass index and AF recurrence, with the highest risk in patients with a BMI of less than 21.3 kilograms per meter squared. Third, age of equal to or greater than 70 years was established as the critical risk threshold for AF recurrence after RF catheter ablation. Fourth, patients with a history of smoking, diabetes, uric acid, and older age had significantly higher recurrence risk, and the role of elevated serum homocysteine, left atrial enlargement, and glucose levels in AF recurrence was highlighted, which suggests potential metabolic intervention targets for atrial fibrillation. Finally, the need for proactive weight management and close monitoring of high-risk patients, particularly those with hyperhomocystinemia and H-type hypertension, was emphasized. The next paper is titled Bleeding Risk in East Asian Patients with Atrial Fibrillation, Validation of the DOAC Score in a Japanese Multicenter Registry by Dr. Takahiko Nishiyama. The author's key findings are as follows. First, the direct oral anticoagulant score demonstrated acceptable discrimination for bleeding risk prediction in Japanese patients with atrial fibrillation with C-index values of 0.704, 95% confidence intervals between 0.634 and 0.774 at 1 year, and 4.7% at 5 years, with the very high-risk group showing significantly higher bleeding rates of 7.1% and 14.3% respectively. Third, the DOAC score outperformed established bleeding risk scores, including HAS-BLED, C-index of 0.523, anticoagulation and risk factors in atrial fibrillation with a C-index of 0.650, and outcomes registry for better informed treatment of atrial fibrillation with a C-index of 0.642 in this study. And finally, modifying antiplatelet scoring by distinguishing aspirin 2 points from other antiplatelets 1 point enhanced the score's discriminative ability with a C-index of 0.707 with a 95% confidence interval of 0.637 to 0.777. The title of the next paper is Proteomic Biomarkers and Biological Pathways Associated with Atrial Fibrillation in Heart Failure Patients with Reduced Ejection Fraction by Dr. Toon, Peterson, and colleagues. The first key finding is atrial fibrillation and heart failure are prevalent comorbidities that have a negative impact on quality of life and mortality. The underlying pathophysiology of heart failure may differ between patients with and without AF. Second, patients with heart failure with reduced ejection fraction and concomitant AF have distinct plasma proteomic profiles compared with patients with HFrEF without AFib. These proteomic profiles are related to various biological mechanisms implicated in the pathophysiology of heart failure, such as elastic fiber assembly, nervous system development, protein glycosylation, and ether lipid metabolism. Next up is a paper titled Atrial Fibrillation in the Emergency Department, Predictors of Admission and Discharge, a Nationwide Analysis by Dr. Alexandra Milhoff and colleagues. The first key finding is that high admission rates, nearly half, 48.4% of emergency department visits for atrial fibrillation resulted in inpatient admission, highlighting the substantial healthcare burden of AF presentations. Second, demographic predictors. Older adults, age equal to or greater than 80 years, and female patients had higher odds of hospital admission than did younger adults and men, respectively. Third, comorbidity impact. Conditions such as hypertension, renal failure, obesity, valvular disease, and substance use were significantly associated with an increased likelihood of hospital admission. And finally, low ED mortality. Despite the high admission rate, ED mortality amongst patients with AFib was very low at 0.03%, suggesting effective triage and acute management in the ED. Next up, the title of this paper is Long-Term Low-Voltage Impedance Measurements in Subcutaneous Implantable Cardioverter Defibrillators by Dr. Giacomo Mugnai and colleagues on behalf of the SICD Rhythm Detect investigators. The key findings of this paper are 1. Low-voltage impedance measurements recorded by the subcutaneous implantable cardioverter defibrillator strongly correlate with high-voltage impedance values measured during 80-joule shock delivery, supporting the potential use of low-voltage impedance as a non-invasive surrogate for high-voltage impedance. Second, low-voltage impedance increased progressively during the first weeks post-implantation and stabilized by the third month. Third, implantation variables such as device positioning, subcutaneous versus intramuscular, and adipose tissue thickness influenced low-voltage impedance values, with lower impedance observed in intramuscular placements and thinner subcoil fat. The title of the next paper is R-wave amplitude changes in lead AVL predict outcomes in cardiac resynchronization therapy, exploring the role of papillary muscle dyssynchrony and mitral regurgitation, by first author Silla Olfos and colleagues. The first key finding is that responders to cardiac resynchronization therapy typically exhibit, after implantation, a decrease in the amplitude of the R wave in lead AVL, a reduction in QRS duration, and a decrease in the severity of mitral regurgitation. Second, lead AVL reflects the electrical activation of the anterolateral wall of the left ventricle and is considered a surrogate marker for the activation of the anterolateral papillary muscle. Third, variations in R-wave amplitude in lead AVL may serve as a prognostic marker for survival in patients undergoing CRT. Next up, this paper is titled Efficacy and Safety of Left Bundle Branch Pacing Compared with Left Ventricular Septal Pacing, a systematic review and meta-analysis by Dr. Ivan Kutra and colleagues. First key finding is that in patients with reduced left ventricular ejection fraction and wide QRS duration, left bundle branch pacing has shown superior efficacy compared with left ventricular septal pacing in maintaining intraventricular electrical synchrony. This led to more substantial improvements in LV systolic function and structural remodeling during follow-up. These benefits were further associated with a significant reduction in the risk of all-cause mortality and heart failure hospitalization. Second, in patients with preserved left ventricular ejection fraction and narrow QRS duration, although the LBBP group demonstrated better preservation of intraventricular synchrony, both groups exhibited similar efficacy in preserving LV systolic function and structural remodeling during follow-up, with comparable risks of heart failure hospitalization. And then finally, both LBBP and LVSP demonstrated comparable safety profiles and procedural efficiency. The title of the next paper is Effectiveness of Cardiac Device Envelopes in Preventing Infections Among Pacemaker Patients, the Reinforced Brady Real-World Project by Dr. Matteo Zacchi and colleagues. The first key finding is the antibacterial envelope was effective even in a lower-risk pacemaker-based population, unlike previous studies mostly focused on implantable cardioverter defibrillator or cardiac resynchronization therapy defibrillator recipients. This analysis included only pacemaker and cardiac resynchronization therapy patients, 73.6% of whom underwent de novo implantation. Despite 67.2% being classified as low risk by the PADET score, the antibacterial envelope still showed benefit. Second, the antibacterial envelope use was associated with a significant reduction in infection rates. Over a mean follow-up of 2.2 years, systemic or pocket infections occurred in 0.3% of patients in the TYRX group versus 1.8% in the control group, with a p-value of 0.05, with a 4-year incidence of 0.4% versus 2.5% respectively. The antibacterial envelope remained an independent predictor of lower infection risk with a hazard ratio of 0.11, p-value of 0.042. Third, the protective effect was evident despite worse baseline characteristics in the TYRX group. Patients receiving the envelope had higher PADET scores. And finally, the antibacterial envelope also showed benefit in single and dual chamber pacemaker recipients in this subgroup made up of 752 patients. The 4-year infection rate was significantly lower in the Tyrix group, 0.6%, than the control group, 3.1%, hazard ratio 7.34, with p-value of 0.033, supporting its use even in standard low-voltage devices. The next paper is titled Cardiac Resynchronization Therapy in Chronic Chagas Cardiomyopathy, a systematic review and single-arm meta-analysis by Dr. Yuri Felix and colleagues. The first key finding is that in patients with chronic Chagas cardiomyopathy undergoing CRT, the all-cause death rate was 38%, 95% confidence interval 21 to 56. It is primarily driven by cardiovascular death, 29%, and the non-cardiac death rate was 4%. After CRT, the proportion of patients rated New York Heart Association Class 3-4 improved to 21% from 87% at baseline. Poole post-CRT left ventricular ejection fraction was 36.3%. And finally, in Chagas cardiomyopathy after CRT, CRT was associated with improvements in LVEF and symptomatic and functional burden Class 3-4. However, overall mortality remained elevated. The title of the next paper is Clinical Presentation and Outcomes of Patients with Biallelic SCN5A Variants, a Systematic Review by Dr. Elodie Serget and colleagues. First key finding is that most frequent cardiac phenotypes in patients with biallelic SCN5A variations are sinus node dysfunction, progressive cardiac conduction disease, and Brugada syndrome. Patients with biallelic SCN5A variants frequently present with early onset and severe cardiac phenotypes. Non-missense variants are associated with worse outcomes. They are significantly associated with younger age at diagnosis, proband status, and a higher risk of major cardiac events. Despite a high prevalence of stroke, only 5% of patients received anticoagulation, suggesting that the risk of cardioembolic complications may be underestimated in this population. The title of the next paper is Utility of Short-Term Heart Rate Variability Metrics in Heart Failure with Reduced Ejection Fraction by Dr. Michiaki Nagai. The first key finding is that in this study, myocardial functional recovery in heart failure with reduced ejection fraction was closely observed with short-term non-conventional heart rate variability indices. Second, triangular index at 2-minute and sympathetic nervous system index at 9-minute electrocardiogram intervals had a higher discrimination ability for the ejection fraction recovery phenotype. 3, ultra-short-term triangular index and short-term SNS index are useful to distinguish between recovered and non-recovered HFrEF. Fourth, in particular, the relationship between the ultra-short-term triangular index and heart failure with recovered ejection fraction was independent of N-terminal pro-B-type natriuretic peptide level. The title of the next paper is Management and Outcome of Different Types of Ventricular Tachycardia Associated with Hypokalemia by Dr. Michaela Ebert and colleagues. First key finding is that this study identifies poor overall outcome in patients with hypokalemia-associated sustained ventricular tachyarrhythmias even after prompt correction of hypokalemia. Second, patients with sustained monomorphic ventricular tachycardia had higher recurrence rates, higher median potassium levels, and lower ventricular tachycardia-free survival at 24 months than did those with polymorphic VT or ventricular fibrillation, and more often presented with the moderate to severe hypokalemia. Third, these findings challenge the notion that hypokalemia-associated sustained monomorphic VT is a reversible condition, instead suggesting the presence of an underlying arrhythmogenic substrate. 4, substrate-specific antiarrhythmic therapy significantly improves outcomes in patients with sustained monomorphic VT compared with potassium correction alone, highlighting the need for individualized treatment strategies. The next paper is a research letter. It is titled Mitigation of Pacing-Induced Cardiomyopathy with Superficial Right Ventricular Mid-Septal Pacing. Failure of statute-driven leads to duplicate 3830 success by Dr. Kenneth Wade McBride and colleagues. There are 3 key findings. The first one, traditional methods of right ventricular pacing have resulted in significant occurrences of pacing-induced cardiomyopathy. Second, active fixation 3830 leads placed in the superficial RV mid-septum using the C315 His delivery catheters have recently been demonstrated to mitigate the occurrence of pacing-induced cardiomyopathy. Third, our experience with stylet-driven leads did not achieve the same benefit. The title of the next paper is Target Delineation Workflow and Outcomes of Stereotactic Cardiac Radioablation by Dr. Muhammad Afzal and colleagues. The first key finding is that multidisciplinary workflow is essential. Stereotactic body radiation therapy target delineation was achieved through the integration of imaging, electroanatomic mapping, and electrophysiologic data requiring collaboration amongst electrophysiologists and radiation oncologists. Second, significant reduction in ventricular tachycardia burden. SBRT resulted in a significant reduction in sustained VT burden, as well as implantable cardioverter defibrillator delivered anti-tachycardia pacing and shock therapies among patients with refractory VT who survived to the 6-month follow-up without requiring cardiac transplantation. Third, SBRT is feasible and well tolerated. Most SBRT sessions were performed in the outpatient setting with good tolerability and no acute procedural complications. 4. Radiation dose management is critical. Selective underdosing and strict dose constraints on surrounding structures are necessary to limit the risk of radiation toxicity. This reflects the importance of individualized radiation planning. Next up, the title is Impact of Electrode Tissue Proximity on Formation of Pulsed Field Ablation Lesions Using Multi-Electrode Impedance Measurements by Dr. Marian Gruen and colleagues. First key finding is that in a porcine study after a 3-week follow-up period, pulsed field ablation lesions on the right ventricle were wider compared to lesions on the left ventricle. 2. Upon histology, a higher tissue proximity index used during PFA ablation was associated with deeper and larger lesions. The lesion depth was 1.3 plus or minus 0.5 millimeters versus 1.5 plus minus 0.5 millimeters, p-value equals 0.016. And lesion area, 6.4 plus or minus 2.7 millimeters squared versus 8.3 plus or minus 2.9 millimeters squared. And then finally, confirmation of tissue contact using impedance-based measurements may improve PFA ablation efficacy in a clinical setting. Next up, the title of this paper is Arrhythmia Substrate Identification Using Wideband Motion-Corrected Late Gadolinium Enhancement Magnetic Resonance Imaging in a Swine Model of Myocardial Infarction with Taped Implantable Cardioverter Defibrillators by Dr. Calder, Shigren, and colleagues. The first key finding is that late gadolinium enhancement, or LGE, imaging in the presence of an ICD is feasible at 3 Tesla, as demonstrated in a preclinical model of myocardial infarction. Second, a statistically significant increase in heterogeneous tissue corridor count was present with wideband motion-corrected LGE, with an ICD present compared with conventional 2-dimensional and 3-dimensional LGE without an ICD, causing a reduction in specificity to arrhythmogenic tissue. Third, phase-sensitive inversion recovery contrast, as used in clinical protocols, increases the number of heterogeneous tissue corridors found in the data, which may affect clinical interpretation of LGE images in the ventricular tachycardia ablation planning pipeline. The next paper is titled Spatiotemporal Tissue Temperature During Cryoballoon Ablation Using Different Balloons by Dr. Akil Chikata. First key finding, spatial temperature evaluation in an in vitro model suggests differences in cooling profiles between the 2 commercially available balloons. Second, the minimum force required for pulmonary vein occlusion was significantly lower with Polar X Fit 28 mm compared to AFA Pro. Third, Polar FIT 28 mm achieved the lowest tissue nadir temperature, including instances below minus 50 degrees centigrade, suggesting the potential for creating deep lesions, and Polar X Fit 31 mm generated the broadest area of cooling below minus 30 degrees centigrade, indicating a capacity for creating wider lesion sets. The title of the next paper is Assessment of Physicians' Adherence to Guideline-Directed Medical Therapy Amongst Patients with Heart Failure with Reduced Ejection Fraction at the University of Gondor Comprehensive Specialized Hospital in Northwest Ethiopia 2023. This paper is part of our Global Voices section. The first author is Dr. Sisse Berber and colleagues. The first key finding is that in this study, the physician's adherence to GDMT was good in 40%, moderate in 33.8%, and poor in 26.2% of the studied patients with heart failure with reduced ejection fraction. Age of equal to or greater than 65 years, cause of heart failure specifically, and duration of HFrEF of equal to or greater than 3 years were factors significantly associated with good physicians' adherence to GDMT. Third, GDMT consists of life-saving medications such as ARBs, ACE inhibitors, beta blockers, MRAs, SGLT2 inhibitors. Therefore, this study showed that the utilization of ARB and ACE inhibitors was 69.5%, and only 36.3% of patients were receiving the optimal dose, whereas 63.7% of patients were receiving a suboptimal dose. 52.4% of patients with HFrEF used evidence-based beta blockers, and only 10% were taking the optimal dose, whereas 90% of patients were receiving a suboptimal dose. And finally, 48.8% of the patients with HFrEF were using MRAs, and only 37% received the optimal dose, and 62.9% were receiving the suboptimal dose. Next up is a review paper titled Catheter Ablation of Macro-Reentrant Atrial Tachycardia in Adults with Epstein Anomaly, a Narrative Review by Dr. Norman Wang and colleagues. The first key finding is that in adults with Epstein's anomaly, macro-reentrant atrial tachycardia are almost exclusively confined to the right atrium, and most are dependent upon the cable tricuspid isthmus. Second, physiological status assessment and pre-procedural cardiac imaging may assist in planning strategies for cardiac electrophysiology study and catheter ablation. Third, state-of-the-art technology in the cardiac electrophysiology laboratory may optimize the effectiveness and safety of catheter ablation. And finally, long-term recurrence of atrial tachyarrhythmias following catheter ablation appears to be high. Next is a paper from our Fellows Corner. The title is A Stitch in Time, a Successful Case of Refractory VT by Dr. Rita Amador and colleagues. The key findings are that 1. Intractable ventricular tachycardia is a cardiac emergency requiring timely, increasingly invasive interventions to support circulation and suppress the arrhythmia. Second, although catheter-based ablation can effectively eliminate VT, its use may necessitate concomitant, short-term mechanical circulatory support for optimal outcomes. And third, although substrate-based approaches have proven efficacy in eliminating VT, targeting the clinical tachycardia may be necessary in some patients. The next paper is a research letter. The title is Mitigation of Pacing-Induced Cardiomyopathy with Superficial Right Ventricular Mid-Septal Pacing. Failure of stylet-driven leads to duplicate 3830 success by Dr. Kenneth McBride and colleagues. First key finding is that traditional methods of right ventricular pacing have resulted in significant occurrences of pacing-induced cardiomyopathy. 2. Active fixation 3830 leads placed in the superficial RV mid-septum using the C315 HIS delivery catheters have recently been demonstrated to mitigate the occurrence of pacing-induced cardiomyopathy. Third, the author's experience with stylet-driven leads did not achieve the same benefit. The next paper is also a research letter. The title is Comparative Thromboelastography with Platelet Mapping Assessment of Coagulation Profiles in Post-Ablation versus Non-Ablated Patients with Paroxysmal Atrial Fibrillation and Peripheral Artery Disease, Implications for Thrombotic Risk by Dr. Isabella Chiri and colleagues. The first key finding is that persistent platelet hyperreactivity after ablation, catheter ablation for atrial fibrillation induced significant platelet hyperreactivity that persisted 2 to 3 months after the procedure, with ADP aggregation nearly doubling, 81.55% versus 36.75%, p equals 0.0.2. Compared with non-ablated controls despite more intensive antiplatelet therapy in the ablated group. Second, enhanced clot strength despite anticoagulation. Maximum clot strength parameters were significantly elevated in post-ablation patients with ADP maximum amplitude increasing by 90% and kaolin heparinase maximum amplitude rising by 18%. Third, thromboelastography with platelet mapping reveals hidden thrombotic risk. Thromboelastography with platelet mapping detected significant coagulation abnormalities in post-ablation patients that would be missed by conventional coagulation tests, suggesting a potential role for advanced hemostatic monitoring and personalizing post-ablation anticoagulation strategies. Finally, extended vulnerable period. The prothrombotic state after catheter ablation extends well beyond the traditionally recognized acute phase, persisting for months and potentially explaining the temporal disconnect between ablation procedures and subsequent unexpected thrombotic events. The title of the next research letter paper is Early Experience with Pulsed Field Ablation for Atrial Fibrillation in Central Asia, a Case Series, for Dr. Ayan Adrakhmonov and colleagues. The first key finding is, to the author's knowledge, this is the first reported case series of PFA for atrial fibrillation in Central Asia. 2, all patients remained in sinus rhythm at 3 and 6 months of follow-up. Third, in patients with heart failure with mildly reduced ejection fraction, PFA led to improved left ventricular function and reduced left atrial volume index. And finally, no atrial fibrillation recurrence or significant arrhythmias occurred during follow-up. The next and final paper is an editorial. This is by Dr. Mirbad Albumati and colleagues. The title is Cardiorhythm Congress 2025, Marking a Milestone, Embracing a New Chapter. We are very pleased to be able to publish the abstracts for the 2025 Cardiorhythm Congress taking place in Rwanda this year. The African Heart Rhythm Association has grown significantly over the past couple of years after a restructuring of the organization. This has catalyzed a new era of growth, collaboration, and educational leadership in cardiac electrophysiology throughout Africa. Dr. Albumati states that AFRA, the association AFHRA, has emerged not only as a continental force, but also as a global thought leader in the field of heart rhythm management. And again, we are so pleased to be able to publish all of the abstracts from this exciting Congress. Well, that ends the podcast for September 2025. Thank you so much again, as always, for listening, and I will talk to you again next month.